it is a very vast topic. It could not be covered in just one session. We already covered the anatomical, physiological, pathological and pharmacological aspects of the topic in the 9th UGCR. And this time we shall cover the clinical aspects of the topic hypertension. The UGCR is prepared by our MBBS students under the guidance of the heads of the respective departments with the supervision of their subject moderators. The chairpersons for today's undergraduate combined rounds are Dr. Mukesh Sarna, Dr. Rajiv Sharma, Dr. Amit Agrawal and Dr. Pankaj Kumar Singh. I appreciate the hard work which is put in every month by our undergraduate students to prepare this UGCR, and I hope this shall continue and flourish in the same way. Now, I invite Dr. Dipesh Agrawal sir for his expert comments and introduction to the topic hypertension.
Good morning, all of you. So, last time, as I said, we discussed about anatomical, physiological, pathological and pharmacological aspect of hypertension. And today, we will discuss about clinical aspect of hypertension, right? So for hypertension, we know the definition of hypertension is whenever your blood pressure, office blood pressure is more than or equal to 140 systolic, 90 or more than 90 diastolic millimeter mercury, right? And that is for adults. Adults means age more than 18 years of age. So I hope everyone here is that. And how many of you know your blood pressure? Please raise your hand. Students. Hardly 1% or 2%. So now the guideline says screening of hypertension is very important. And to screen hypertension, you can reduce your complications, especially cardiovascular and neurological complications, right? And everybody, as per American guideline as well as European and Indian guidelines, they say everybody should screen your blood pressure starting at the age of 18 years. So आज ही सभी लोग जाएंगे अपना अपना ब्लड प्रेशर चेक करेंगे और बिलीव मी आप में से कुछ ना कुछ का ब्लड प्रेशर थोड़ा हायर रेंज में मिलेगा, right? So screening is very important to reduce complications of blood pressure. That is, it may be in terms of heart failure, renal failure, or stroke, ischemic stroke or hemorrhagic stroke, and then retinopathy. These are four main organs which are involved because of high blood pressure, persistent high blood pressure. And then, if you are not able to control, then sometimes or other, you may end up into hypertensive crisis. So what is hypertensive crisis? Anybody? Acute rise of blood pressure, systolic blood pressure of more than 180 and diastolic blood pressure of more than 120 millimeter mercury, equal to or more than 180 by 120. Acute rise. Now it is again classified into two. Either urgency or emergency. So there is a difference between hypertensive urgency and emergency. Emergency when you require immediate attention. So patient, those who are having blood pressure of more than 180 by 120 along with body organ damage one or other. So it may involve your heart, it may involve your brain, kidney or eyes. So patients with stroke, patient with chest pain, patient with heart failure, patient with renal failure, with acute rise of 180 by 120 is hypertensive emergency. They require utmost care with immediate reduction of blood pressure within next 1 to 2 hours with IV medications. And then hypertensive urgency where acute rise of blood pressure of the same level but without any evidence of organ damage. They may have tingling, numbness, headache, other features, but organs are not involved yet. They again require urgent treatment in terms of reduction of blood pressure in next 24 to 48 hours. So slightly you can slow down for reduction of blood pressure. So these two complications you should keep in your mind while treating your patient and while checking your blood pressure, right? Now apart from that, measurement of blood pressure is very important aspect. How to measure, probably they will tell you. So many a times when we see the patients are coming into your OPD or anywhere, just start measuring your blood pressure while patients are sitting or standing. This is not the right way. Just keep your patient calm and quiet. Rest for 5 to 10 minutes without taking any coffee or stimulants, and then you check your blood pressure at the level of heart, keeping your cuff at the level of heart, and check at least 3 readings. You can discard first, and next two readings average is your systolic and diastolic blood pressure. That is actual way, right? Or you can have a supine blood pressure. And then office blood pressure is probably slightly higher than your home blood pressure. Home blood pressure is around 5 millimeter lower as compared to hospital or doctor's chamber blood pressure. So many a times patients are coming, sir, मेरा घर में तो blood pressure ठीक रहता है, आपके chamber में आकर बढ़ गया है. They may be right. So that is known as white coat hypertension. Similarly, opposite to white coat hypertension is reverse white coat hypertension, when patients are having normal blood pressure at doctor's chamber, but they may have higher blood pressure at home or at workplace. That is known as reverse white coat hypertension. But how will you diagnose? So when you are seeing a normal blood pressure patient and in investigation you are finding organ damage, like in ECG or echo you are having left ventricular hypertrophy, or you are having retinopathy or nephropathy, probably hypertensive nephropathy or retinopathy, with normal office blood pressure, these patients may have reverse white coat hypertension. Now to confirm, they require home blood pressure monitoring or ambulatory blood pressure monitoring. So these few small definitions and diagnostic dilemma you should keep your mind while treating and managing your patients. Thank you very much.
Thank you very much, Deepesh sir, for enlightening us today. Good morning, dignitaries, esteemed faculty members, and my fellow colleagues. Today, under the guidance of Dr. Shrikant Chaudhary sir, under the guidance of Dr. Puneet Rajwani sir, Professor and Head Department of General Medicine, under the moderatorship of Dr. Shrikant Chaudhary sir, Associate Professor, Department of General Medicine, alongside Dhruv Dusad, Divya Yadav, Mokshi Ramlakhani, Pooja Gujar, I, Divyanshi Singh, representing the batch of 2023 second professional, would like to present on the topic clinical features, complications, and management of hypertension. As previously discussed in UGCR Part 1 on hypertension, it is defined as the condition when blood pressure within the arteries is persistently above a systolic blood pressure of more than or equal to 140 millimeters of mercury and a diastolic blood pressure of more than or equal to 90 millimeters of mercury. We have adopted the European Society of Cardiology guidelines for the classification of hypertension on the basis of range, with the optimal blood pressure values being less than 120 millimeters and less than 80 millimeters. The normal values range between 120 to 129 millimeters and 80 to 84 millimeters. The high normal values vary between 130 to 139 millimeters and or 85 to 89 millimeters. Grade 1 hypertension cases present with systolic blood pressure values varying between 140 to 159 millimeters and or diastolic blood pressure values varying between 90 to 99 millimeters. Grade 2 hypertension cases present with systolic blood pressure varying between 160 to 169 millimeters and diastolic blood pressure varying between 100 to 109 millimeters. Whereas in grade 3 hypertension cases, the systolic blood pressure may rise as high as 180 millimeters and the diastolic blood pressure may rise as high as more than 110 millimeters. In isolated systolic hypertension, the systolic blood pressure remains around 140 millimeters and the diastolic blood pressure remains less than 90 millimeters. In isolated diastolic hypertension, the systolic blood pressure remains 140 millimeters and the diastolic blood pressure can go above 90 millimeters. Hypertension can be broadly classified into primary and secondary hypertension on the basis of etiology. Primary hypertension is the elevation in blood pressure without an identified cause, whereas secondary hypertension is the elevation in blood pressure with its etiology being known. This type accounts for about 5 to 10% of the total cases of hypertension. Causes of secondary hypertension might be the following: renal diseases, coarctation of aorta, endocrine disorders like Cushing syndrome and acromegaly, neurological disorders like brain tumors and head injury, sleep apnea, and medications like oral contraceptive pills, non-steroidal anti-inflammatory drugs, and cocaine. Clinical features of hypertension. Usually high blood pressure in itself does not cause any symptoms, hence hypertension is also referred to as the silent killer disease. Clinical features at advanced stages are as follows, with the symptoms being occipital headache, dizziness, epistaxis, blurred vision, confusion, and shortness of breath. And the signs being heaving apex impulse, loud A2 sounds, the fourth heart sound being heard, and fundal changes. Specific findings can be attributed to certain disorders that can be the cause of secondary hypertension, such as paroxysmal hypertension, palpitations, headache, and diaphoresis in cases of pheochromocytoma, oliguria, edema, and anemia in cases of chronic kidney disease, obesity, snoring, and daytime sleepiness pertaining to obstructive sleep apnea, weight gain, muscle weakness, stridor, obesity, amenorrhea, and most importantly, moon feces in cases of Cushing syndrome, abdominal or renal growth in cases of renovascular cause. Weight loss, tachycardia, tremors, heat intolerance, and systolic hypertension pertaining to hyperthyroidism, headaches, fatigue, visual disturbances, enlarged tongue and enlarged extremities pertaining to acromegaly, muscle cramps, weakness and fatigue pertaining to aldosteronism and depression, muscle weakness, kidney stones, and osteoporosis being indicative of hyperparathyroidism. Hypertension can be the cause of many systemic complications, starting off with the cerebrovascular system. It can cause transient ischemic attacks, ischemic or hemorrhagic stroke, vascular dementia, and hypertensive encephalopathy. In cases of cardiovascular system, it can cause left ventricular hypertrophy, coronary artery disease, myocardial infarction, angina pectoris, congestive heart failure, and dissecting aortic aneurysm. In the eyes, it can cause hypertensive retinopathy. In the kidneys, it is the leading cause of chronic kidney disease, hypertensive nephropathy, renal artery stenosis, albuminuria, nephrosclerosis, and end-stage renal disease. It can also lead to several peripheral artery diseases such as atherosclerosis, Raynaud's disease, intermittent claudication, and gangrene. Management of hypertension. To approach a hypertensive patient, it is important that we especially focus on their family history, their lifestyle such as exercise, salt intake, and smoking, other risk factors, and history of drug intake or alcohol. Complaints suggestive of secondary hypertension or end organ damage may be present. For measurement of blood pressure, the following conditions should be followed. Using a validated upper arm cuff device, measuring in a quiet room with comfortable temperature, as the patient already said, no smoking, caffeine, food, drug intake or exercise 30 minutes before measurement. The subject should remain seated and relaxed for 3 to 5 minutes, and the subject mustn't talk during or between the measurements. The subject should be sitting with their back supported by a chair, with their legs uncrossed and feet flat on the floor, and their bare arm resting on a table mid-arm at heart level. For measurement at an office or in a hospital setting, we take 3 readings with minimum 1 minute interval between each, and we use the average of the last 2. Whereas for measurement at home, we take 2 readings with 1 minute interval between the 2, and we use the average of the 2. Ambulatory blood pressure monitoring. It records the blood pressure at preset intervals such as 15 to 20 minutes during the day and usually 30 to 60 minutes during the night time, while the patient goes about their normal daily activities over 24 hours. Values indicative of hypertension. Values indicative of hypertension in cases of ambulatory blood pressure monitoring are a systolic blood pressure of more than or equal to 135 and a diastolic blood pressure of more than or equal to 85 millimeters during the daytime, a systolic blood pressure of more than or equal to 120 millimeters, and a diastolic blood pressure of more than or equal to 70 millimeters during the night time, and most importantly, the 24-hour mean values, with systolic blood pressure being more than or equal to 130 millimeters, and diastolic blood pressure values being more than or equal to 80 millimeters are indicative of hypertension. Ambulatory blood pressure monitoring is particularly useful for diagnosing and managing hypertension, especially white coat hypertension and office blood pressure, evaluating the effectiveness of hypertension treatment, and detecting nocturnal hypertension and blood pressure variability, which are key predictors of cardiovascular events, resistant hypertension, autonomic dysfunction, and hypotension in cases of treatment with antihypertensive medications. In cases of primary hypertension, the following investigations should be conducted with basic testing including fasting blood glucose levels, complete blood count, lipid profile, serum creatinine levels, serum sodium, potassium and calcium levels, thyroid stimulating hormone levels, urine analysis and electrocardiogram. The optional testing includes echocardiogram, uric acid and urinary albumin to creatinine ratio. Specific investigations for certain causes of secondary hypertension can be 24-hour urinary metanephrines or catecholamines, plasma catecholamines, and MRI of adrenal gland in cases of pheochromocytoma, thyroid function test in cases of thyroid disease, insulin-like growth factor 1, and growth hormone suppression testing following oral glucose load, and MRI brain in cases of acromegaly, bone profile in cases of hyperparathyroidism, sleep polysomnography in cases of obstructive sleep apnea, renal function test, duplex scan, CT or MRI, urine analysis, and ultrasound of kidneys in cases of renal diseases, 24-hour urinary cortisol, dexamethasone testing, and imaging in cases of Cushing syndrome. Treatment of hypertension can be done in two ways, just lifestyle modification and pharmacological therapy. Management by lifestyle modification includes weight reduction, that is, to maintain a normal body weight with BMI varying between 18.5 and 24.9, to adopt a DASH eating plan, which is a dietary approach to stop hypertension, that is, to consume a diet rich in fruits, vegetables, and low-fat dairy products with a reduced content of saturated and total fat. Dietary sodium reduction, that is, to reduce dietary sodium intake to no more than 100 milliequivalents per liter, which is 2.4 grams sodium or 6 grams of sodium chloride. Physical activity, to engage in regular aerobic physical activity such as brisk walking at least 30 minutes per day for most days of the week. Moderation of alcohol consumption, that is, to limit consumption to no more than 2 drinks per day for most men and 1 drink per day for most women. Pharmacological treatment. We usually start with monotherapy in selected patients, that is, in patients with low-risk hypertension and BP being less than 150 by 95 millimeters of mercury, or in patients with high normal BP and high cardiovascular risk, or in frail patients or in patients with advanced stage. We then start with dual combination therapy in most patients. We prefer single pill combinations at any step. Step 1. Dual combination. That is angiotensin converting enzyme inhibitors or angiotensin 2 receptor blockers with calcium channel blockers or thiazide-like diuretics. We increase it to full dose if it is well tolerated, and up to 60% of the cases of hypertension can be controlled with this step. Step 2. Triple combination. Angiotensin converting enzyme inhibitor or angiotensin 2 receptor blockers with calcium channel blockers and thiazide-like diuretics. It is increased to full dose if it is well tolerated, and about 90% of the total cases can be controlled up to here. If still not managed, it is known as the true resistant hypertension, which is seen in about 5% cases. The patient must then consult a hypertension specialist. Beta blockers can be used as monotherapy or at any step of combination therapy. Hypertension with other comorbidities. In cases of diabetes mellitus, the drugs of choice are angiotensin converting enzyme inhibitors, angiotensin 2 receptor blockers or calcium channel blockers. In cases of dyslipidemia, angiotensin 2 receptor blockers, amlodipine, indapamide, labetalol and clonidine. In cases of obesity, angiotensin converting enzyme inhibitors, angiotensin 2 receptor blockers or calcium channel blockers, vasodilating beta blockers and diuretics. In cases of benign enlargement of prostate, alpha blockers are used. is already briefed by Deepesh sir. Hypertensive emergency is a case of severe hypertension with usually diastolic blood pressure being more than 120 millimeters of mercury. Evidence of acute organ damage is usually present. Hypertensive emergencies are life-threatening and they require immediate treatment with IV drug labetalol, nitroprusside, nicardipine and nitroglycerin. Hypertensive urgency. Again a case of severe hypertension with a diastolic blood pressure of more than 120 millimeters of mercury. However, there is no acute end organ damage and most cases are asymptomatic and the treatment can be done with oral drugs. And now I'd like to invite the presenter from the Department of Ophthalmology.
Good morning, Excellencies, respected faculty members, and my fellow colleagues. I, Rakshit, along with the help of my team members, Aman Singh, Ananya Tang, Shubhi Srivastava, and Somil Chaudhary, am here to present on the topic hypertensive retinopathy. This presentation was formed under the guidance of Dr. C.P. Gupta sir, Professor and Head, Department of Ophthalmology, and with the moderatorship of Dr. Sarita Jain ma'am. At the end of this presentation, you will be able to appreciate what is hypertensive retinopathy, what is its pathogenesis, pathophysiology, classification, management, and other ocular complications of hypertension. Systemic hypertension could have three manifestations: retinopathy, choroidopathy, or optic neuropathy. Hypertensive retinopathy is defined as fundus changes occurring from elevated systemic arterial blood pressure. This is a picture of normal fundus showing optic disc on the nasal side with retinal arterioles and venules emerging from its center, and here on the temporal side the fovea centralis with surrounding macula lutea. Here is the contrast between normal fundus and fundus following hypertensive retinopathic changes, about which we will study in detail. Systemic hypertension also causes pathological alterations in choroid and optic nerve. Pathogenesis of hypertensive retinopathy causes vascular and extravascular changes in retina, and it unfolds as follows. Chronic systemic hypertension over time leads to arteriosclerosis, which will cause retinal arteriolar constriction and culminating into ischemic damage of arterial wall, which will cause smooth muscle degeneration and leads to focal break-ins due to the loss of fibromuscular support for endothelium. The plasma will seep into the vessel wall and further obliterate the lumen, leading to a vicious cycle, as we can see in this diagram. The increased pressure and continuous damage will further increase the capillary permeability, leading to extravascular manifestations of hypertensive retinopathy. Retinal hemorrhages can be seen as dot shape or flame shape, depending on the respective perpendicular or parallel orientation of the layer in which they are present with respect to the inner limiting membrane. The pathophysiology of hypertensive retinopathy has four phases. In vasoconstrictive phase, the vasospasm leads to a decrease in arteriole to venule ratio to 1:3 and ischemia of choroid, retinal pigmented epithelium, and optic nerve head, which is clinically seen as generalized narrowing of retinal arterioles on the ophthalmoscope, as shown in this picture. Coming to sclerotic phase, which is characterized by intimal thickening, hyperplasia of tunica media, and hyaline degeneration, which is clinically observed as more focal arteriolar narrowing, presence of silver wiring, or changes at arteriovenous crossings. Moving on to exudative phase, in which blood-retinal barrier becomes disrupted due to hypoxia, leading to dot or flame-shaped hemorrhages, hard exudates, or cotton wool spots, as shown in this diagram. Malignant hypertension is rapid progression of hypertensive state in a patient whose arterioles are not defended by the fibrosis from its effect of raised blood pressure. It is manifested as retinopathy, which we had just discussed, as choroidopathy, leading to neurosensory retinal pigmented epithelium detachments, and optic neuropathy, characterized by optic disc edema. Hypertensive retinopathy is classified according to two systems of classification. Kitt-Wagner-Baker system classify it from grade 1 to 4, and Mitchell-Wong system classify it from mild to malignant. The changes seen in grade 1 hypertensive retinopathy are mild generalized arteriolar attenuation as shown here and broadening of arteriolar light reflex. In grade 2 hypertensive retinopathy, there is generalized narrowing and focal attenuation of the arterioles and a positive salus sign in which the vein is deflected from its original path at AV crossing. In grade 3 retinopathy, there is copper wiring of the arterioles, positive gun sign characterized by tapering of the veins at the either side of AV crossing, positive bonnet sign characterized by banking of the veins distal to arteriovenous crossing. Other signs are flame-shaped hemorrhages, cotton wool spots, and hard exudates. In grade 4 retinopathy, along with all the grade 3 signs, there is silver wiring of the arterioles and papillary edema. Coming down to the management of the hypertensive retinopathy, in mild conditions, BP control and regulation and regular monitoring is required. In moderate conditions, along with the blood pressure control, diabetes and cardiovascular abnormalities need to be ruled out. In malignant hypertensive retinopathy, urgent stepwise control of blood pressure over a few hours is done with a monitoring for and organ damage. In the end, some other ocular complications of hypertension are central retinal artery or vein occlusion, anterior ischemic optic neuropathy, epiretinal membrane formation, or cystoid macular edema. Thank you. Now I would like to call my colleague from Department of Nephrology.
Good morning, esteemed faculty members, dignitaries, my fellow batchmates and juniors. I am Mansi Mishra. On the behalf of the Department of Nephrology, will be presenting the 10th UGCR. Good morning, esteemed dignitaries, respected faculty members, my fellow batchmates and juniors. My name is Mansi Mishra, and on the behalf of the Department of Nephrology, I'll be presenting the 10th UGCR on hypertensive nephropathy under the able guidance of Dr. Suraj Godara Sir, Professor and Head, Department of Nephrology, and with the help of my batchmates Dakshata Chaudhary, Dipanshi Meherwal, Pratham Solanki and Rohit Bhargav. Having a basic outro what hypertensive nephropathy is in general, it's basically renal dysfunction solely attributed to effects of hypertension. Also, it's the uncommon sole cause of renal disease. In further stages, it worsens renal disease. Now here it is important to distinguish it from renal disorders and chronic kidney disorders due to primary renal disease such as glomerulonephritis, causing CKD and hypertension. Moving towards the general clinical profile of the disease, what we have is poorly controlled moderate to severe hypertension, leading to gradual and milder worsening of renal function, further leading to long-standing hypertension before the onset of renal disease. Also, this is usually not prominent with primary hypertension, and if there is a secondary cause, it must be sought after specifically. Moving forwards towards the pathogenesis of the disease, what we see is the first step is arteriosclerosis, which is nothing but narrowing of arteriolar walls with hyaline accumulation in the beginning, which manifests into ischemia, which further leads to tubular atrophy, interstitial fibrosis, glomerular alteration, and periglomerular fibrosis. Now this pathogenesis has basically underlying two conventional theories. The first one would be of glomerular ischemia. As the name suggests, decrease in oxygen supply leads to decrease in size of kidneys, arterial stiffening involving breakdown of elastic fibers and intima. Long-standing hypertension leads to endothelium damage, which further leads to building up of plaques in renal arteries, causing stenosis and ischemic kidney disease. The second theory is of glomerular hypertension and glomerular infiltration. Now this is an alternative mechanism of hypertensive nephropathy, and thus glomerular infiltration and hypertension may occur simultaneously. Here, hypertension results in sclerosis and reduced kidney function. Now as a compensatory mechanism, in unaffected nephrons vasodilate to increase blood flow and hence to increase kidney perfusion, which manifests as increased blood flow to the glomeruli. Now, how will we diagnose hypertensive neuropathy? What we'll first do is urine examination. We'll look for low-grade proteinuria, that is protein amount less than 1 gram, and little to no number of RBCs and WBCs. Now, here what we mean to indicate if we have high number of proteins and if we have high RBCs and WBCs, then we rule out primary renal disorders. And high number for RBCs would be indicative of glomerular nephritis, and high WBCs would be indicative of interstitial tubular diseases. The next test will do is the USG or the ultrasound. Usually we'll find normally sized kidneys. Also we'll have a renal Doppler to diagnose renovascular hypertension as a confirmatory test. And last is renal biopsy. This is the most definite and confirmatory method to diagnose hypertensive nephropathy. This is done when primary renal disease is suspected. Next we'll move towards the microscopical examination of it. In the first slide, as you can see, we see a hypertensive glomerular lesion of the kidneys which manifests into global glomerular collapse, highlighted by the pink area, which is basically filling up a Bowman's capsule with lightly stained collagenous material. In this slide, we can see histopathology of arcuate artery nephrosclerosis, in which we can very clearly see thickened intima and an onion skin-like architecture of the glomeruli. This slide, we can see secondary segmental sclerosis of hypertensive nephropathy. And in this slide, we can clearly see interstitial fibrosis, tubular atrophy, thickened tubular basement membrane, and a fibrous internal thickening of a small artery. Moving forward towards the management of hypertension, as already illumined by my colleagues in the Department of Medicine, we use ACE inhibitors, thiazide-like diuretics, PCBs, beta blockers, aldosterone antagonists, centrally acting agent, and if we discover a secondary cause, then specific treatment should be sought after. But if we have management of CKD in general, a hypertensive nephropathy, our goal would be to retard disease progression and proteinuria along with hypertension. In this, again, we use ACE inhibitors, SGLT inhibitors, along with bicarbonate supplements to prevent acidosis, iron, B12 or erythropoietin supplements to prevent anemia, and calcium vitamin D supplements to as an antidote to mineral disorders. Thank you very much.
UGCR is a teaching activity, so again a request to all future presenters, whenever you want to show an abnormality in an image, radiology, histology, whatever, always put the normal also for comparison. So the students will be better able to appreciate how a normal picture looks and what is the change in the abnormality. Always.
Thank you, sir. Now I would like to invite Dr. Amit Agrawal, sir, Professor, Department of Neurology, for enlightening us about the neurological aspects of hypertension.
I will describe the neurological aspect of the systemic hypertension. The features of the MGUMST, so I provide the outline of our brain, which is the main target of the hypertension complications in our neurology setup. The brain having the cortex and the subcortex. The cortex is the outer line of the brain, and the underneath of the cortex is the subcortical structure, mainly the diencephalon, brainstem, cerebellum. The brain comprising of having a weight of 1200 to 1300 grams of the weight, only 2% of the body weight. But the unique feature of the brain is that it carries extra 20% of the cardiac output. And the other unique feature is that it is totally dependent on the oxygen and the glucose for its survival. So any vascular injury, if persisting more than 2 minutes, leading to the permanent brain injury in the form of the hypoxic brain injury and the hypoglycemic brain injury, which is very fatal and having a grave prognosis. The other unique feature of our cerebrum or brain is that it's autoregulatory system. As in case of renal autoregulatory system, the brain having the itself autoregulatory system, which means is to maintain the central perfusion pressure despite of the marked fluctuation in the mean arterial pressure. So if the systemic hypertension, your mean arterial pressure is fluctuating below in the range of 50 to 150 mmHg, the autoregulatory system maintains the cerebral perfusion pressure adequate, so brain function cannot be compromise. So now I talk about the hypertension which leading to the brain injury. We categorize the neurological complication or brain complication of the hypertension, whether it is because of the persistent hypertension or it because of the acute hypertension. If patient having a chronic hypertension for the years, there is changes in the wall of the arterioles. There are two types of the arterioles in the brain, large vessels and the small vessels. The small vessels supplying the subcortical structure, and the lumen of these subcortical arterioles is like a pin here, hair pin. जो होती है अपनी hair pin जो लगाते हैं उसकी lumen के बराबर होता है, and large vessels having a more lumen. So when there is chronic hypertension, these lead to three types of the clinical manifestation. One is it is the small bleed. So patient having a chronic hypertension, suddenly there is a leakage of the blood which is small, very small in size, leading to the microbleed. Second thing is lateral infarct. It is a diffusion weighted image. In diffusion weighted image there are multiple MRI sequences for diagnosing the neurological disorder. In case of the infarction, the diffusion image, which is a different type of image which fit the infarction. So it is the diffusion weighted image in which the infarct become more prominent and is very small size. So this type of the infarct is called lacunar infarct. जब आप लोगों की पोस्टिंग होगी रेडियोलॉजी में या मेडिसिन ओपीडी में तो यू आर मोर अवेयर क्लिनिकली एज वेल एज थियोरेटिकली कि lacunar infarcts क्या होते हैं. So these are the lacunar infarcts and these are the microbleed. The third clinical aspect of the chronic hypertension leading to the progressive changes in the brain is the second MRI finding. It is the another sequence of the MRI which is called T2 flare, in which the chronic ischemic changes are clearly seen. So these are the areas of the brain showing bilateral hyperintensity. So these supply the leg area as well as the subcortical area. So clinical manifestation of these patients are like of lower body Parkinsonism. I think all of third year or fourth year test is aware of the Parkinson disease. But in this type of the MRI picture, the patient present with vascular Parkinsonism or lower body Parkinsonism. Now we talk about the large vessels disease, in which patient may show the feature of the large infarct, as usually come in emergency as a MC infarct, AC infarct and posterior cerebral artery infarcts. Now what is the effect of the hypertension if there is acute such? There are the well documented three syndromes in the brain is known. Number one is the hypertensive emergency. As discussed earlier, if there is a blood pressure rise of more than 120 mm mercury in diastolic and more than 180 mm mercury in systolic, leading to the disruption of the cerebral autoregulation system. So seepage of the plasma from the intravascular compartment into the surrounding area. So what are the clinical manifestations? Is the headache, vomiting, neurological deficit in the form of seizure, weakness and the hypersensitivity. So it is a hypertensive emergency and patient should be treated according to the line of the hypertensive emergency. The second is posterior reversible encephalopathy syndrome. As the name suggests, posterior means is the posterior part of the brain, mainly the parietal, occipital, brainstem and cerebellum. So these are the posterior compartment of the brain which is damaged by this PRS, posterior reversible encephalopathy syndrome, and the other name is reversible because if you control the hypertension, the MRI finding as well as the clinical scenario improves. These flares occur in the setting of the pregnancy, like eclampsia, preeclampsia, and some nephrological drugs like cyclosporine, cyclophosphamide, tacrolimus. These produce the picture of the flares. And the mechanism of this is same that of the hypertensive encephalopathy, autoregulation system disruption. And third is the interventricular hemorrhage. The most common site of the interventricular hemorrhage or intercerebral hemorrhage is the basal ganglia, thalamus, pons, cerebellum. So in conclusion, the hypertension in neurology can be divided into chronic hypertensive changes, which leading to the lateral infarct, microbleed and vascular Parkinsonism, and acute hypertension changes leading to the posterior reversible ventricular syndrome, hypertensive encephalopathy, as well as the IVH. Thank you.
Thank you, sir. Good morning, Excellencies, respected faculty members, and my fellow colleagues.
Instead of bending down, you can elevate the mic.
Thank you, sir. I, Pramiti Parikh, along with my fellow team members, am here to present on the topic anesthesia and hypertension. This presentation was formed under the guidance of Dr. Vijay Mathur, Professor and Head, Department of Anesthesiology, with the moderatorship of Dr. Pooja Mungya and Dr. Akshita Singla, Assistant Professor, Department of Anesthesiology. White coat hypertension. It is defined as the transient rise in BP from before to during the visit to doctor's clinic, which settles down after period of rest. White coat effect or white coat hypertension is due to increased anxiety leading to high BP in a medical setting with normal ambulatory blood pressure response. Preoperative evaluation. This includes paying close attention to cause, severity of hypertension, current therapy like antihypertensives, any other medication, any related illness like ischemic heart disease, cerebrovascular disease, and renal failure, evidence of end organ damage. Antihypertensive drugs and anesthesia relevance. Antihypertensive drugs like diuretics, which include thiazide, furosemide, spironolactone, they can lead to electrolyte disturbance. Calcium channel blockers like nifedipine, verapamil may cause precipitous hypertension. ACE inhibitors like captopril and enalapril can lead to severe catecholamine-resistant hypotension. Beta blockers like propranolol, labetalol should be avoided in asthmatics and patients with overt CHF. It can also lead to rebound hypertension and myocardial ischemia if withdrawn abruptly. Angiotensin receptor blockers like losartan can lead to severe catecholamine-resistant hypotension. Vasodilators like hydralazine can lead to tachycardia. Centrally acting drugs like clonidine, methyl-dopa can lead to rebound hypertension if withdrawn. Alpha blockers like prazosin can lead to tachycardia. Evaluation. Regular BP monitoring, 12-lead ECG, renal function test with serum electrolytes, 2D echo to look for left ventricular hypertrophy or cardiomyopathies. Preoperative advice. Continuous BP monitoring, control of BP during perioperative period. ACE inhibitors or ARB should be omitted on morning of surgery. Calcium channel blockers, beta blockers and diuretics are to be taken as per schedule. IV fluids to be taken during nil per oral period prior to surgery. Response to perioperative procedures. A rise in blood pressure is noticed due to anxiety and also during induction of anesthesia and extubation. To manage this, following steps are taken, which include pre-medication, induction, maintenance, recovery, pre-medication. The patient should receive anxiolytics. Benzodiazepines on night before and 2 hours prior to surgery help reduce anxiety and associated rise in BP. Induction. Induction with anesthetic agent may lead to sudden fall in BP, which has to be managed aggressively. Maintenance. Careful monitoring of blood and fluid losses and prompt replacement should be performed. Recovery. Cuffing on tracheal tube during emergence will increase blood pressure. Opioids during anesthesia will reduce this tendency. Extubation should be done in a deeper pain. Role of regional anesthesia. Spinal and epidural anesthesia can cause unpredictable hypotension in poorly controlled hypertensive patients. Peripheral nerve block should be considered in hypertensive patients as hazards of general anesthesia is avoided. Intraoperative hypertension. Causes of intraoperative hypertension are as follows. Light plane of anesthesia, pre-existing hypertension, surgical factors, hypercarbia, fluid overload, and drug errors. How to manage that? First, rectify the cause. Deepen the plane of anesthesia. Provide analgesia. Then consider using nitroglycerine 20 mg diluted in 20 to 50 ml, 5% dextrose or normal saline at 0.1 milliliter per kg per hour dose. If tachycardia, use beta blockers like esmolol or metoprolol or labetalol. Problems of anesthetizing a patient with uncontrolled hypertension. Cardiac ischemic events, arrhythmia, cerebrovascular accidents, and excessive surgical bleeding. Hypertensive anesthesia in hypertension. Hypotensive anesthesia in hypertension can be problematic because only 20% fall is allowed from the actual blood pressure of the patient, and thus hypotensive anesthesia is difficult to be achieved in hypertensive patients. Post-operative care. There may be rebound hypertension during extubation. The patient should be extubated in deeper plane of anesthesia to avoid rebound hypertension. Continuous monitoring of blood pressure should be done, and continuation of drugs as per pre-operative schedule as soon as possible after surgery. Thank you. Now, I would like to invite my fellow colleague from Department of Obstetrics and Gynecology.
Good morning, Excellencies, respected faculty members, and my colleagues. Today, I am Sri Bulchandani from Department of Obstetrics and Gynecology is going to talk about pregnancy-induced hypertension. Along with my colleagues, Aryan Sidhu, Happy Chavla, Swarna Sisodia, and Sana Pawar, under the guidance of Dr. Anshul Kulsheshwar, Assistant Professor, and Dr. Usha Shekhawat, Professor and Head Departments of Obstetrics and Gynecology. So basically, ACOG has classified hypertensive disorders in pregnancy under 5 major categories, that are gestational hypertension, preeclampsia, eclampsia, chronic hypertension, and chronic hypertension with superimposed preeclampsia. Now we'll go on with definition of each of these. So what is preeclampsia? It is the new onset hypertension with BP more than or equal to 140/90 mmHg after 20 weeks of gestation and is associated with significant proteinuria or other end organ damage symptoms. Then gestational hypertension, it is the new onset hypertension with BP more than equal to 140/90 mmHg after 20 weeks of gestation without proteinuria or other preeclampsia findings. Then we have chronic hypertension, that is hypertension with BP more than or equal to 140/90 mmHg that precedes pregnancy or develops before 20 weeks of gestation. Then we have chronic hypertension with superimposed preeclampsia, that is chronic hypertension with preeclampsia findings like new onset proteinuria or other end organ dysfunction. Now we go on with the most dreaded complication of preeclampsia, that is eclampsia. That is defined as new onset grand mal seizures in a woman with preeclampsia. Now, preeclampsia is further divided into preeclampsia with severe features or without severe features based on these end organ damage signs. Now we go on with risk factors for preeclampsia, that is couple related factors including primary gravida, pregnancy after donor insemination, donor egg or donor embryo, maternal or pregnancy related factors, that is age less than 18 years or more than 35 years, obesity, smoking, conception after assisted reproductive techniques, history of preeclampsia and previous pregnancy, family history of preeclampsia. Then we have other medical disorders like history of PCOS, pre-gestational diabetes, chronic hypertension and chronic renal failure. Now we go on to etiology of preeclampsia. So basically there is abnormal trophoblastic invasion of uterine vessels, immunological maladaptive tolerance between maternal, paternal and fetal tissues, maternal maladaptation to cardiovascular or inflammatory changes of normal pregnancy. Then we have genetic factors and oxidative stress. So here on the here we see normal pregnancy in which we have large tortuous vessels and large bore vessels which make the BP low, that is low resistance, and on the right hand side we can see preeclampsia in which we have thin vessels which increases the BP due to abnormal trophoblastic invasion. The trophoblasts do not invade the decidua, it only constricts to myometrium. While here we see the complete trophoblastic invasion. Then we have idiopathogenesis, in which we have certain factors like maternal risk factors, genetic factors, abnormal trophoblastic invasion and immunological factors, which further lead to imbalance in angiogenic and anti-angiogenic markers, that is decrease in angiogenic proteins and increase in angiogenic proteins, which further lead to endothelial dysfunction, pro-inflammation and pro-coagulation, which further leads to an organ dysfunction. Then we have prevention of preeclampsia, in which we go on with lifestyle modification, regular physical activity, regular antenatal checkup for early detection of risk factors, low dose aspirin, that is 75 to 150 milligrams per day as per risk assessment. Calcium supplementation is given, heparin with or without aspirin as recommended in APLA. Then we have clinical features of preeclampsia, in which we have mild symptoms like slight swelling over ankles that does not relieve on rest. Gradually the swelling extends to face, abdominal wall, vulva and even the whole body. Then we have alarming symptoms like persistent frontal or occipital headache, blurred vision, photophobia, epigastric or right upper quadrant pain and altered mental status. Then we have signs of preeclampsia, in which we have abnormal weight gain of more than 2.2 kilograms in a month or more than 450 grams in a week, persistent rise of blood pressure with more than 140 by 90 mmHg, visible edema over ankles from rise of bed at morning, signs of pulmonary edema, abdominal examination revealing scanty liquor or fetal growth restriction due to chronic placental insufficiency. Now, we have certain objectives in mind when we treat preeclampsia patients, that is to stabilize hypertension and prevent progression to severe preeclampsia, to prevent eclampsia, to prevent complications and delivery of a healthy fetus in optimal time, restoration of health of mother in perpurium. Treatment is mostly empirical and symptomatic, but the definitive treatment is termination of pregnancy. Now we go on with clinical assessment, in which we clinically evaluate for symptoms like headache, right upper quadrant pain or epigastric pain, visual disturbances or oliguria that are end organ dysfunction, that indicate end organ dysfunction, blood pressure recording, daily weight recording, fluid intake and urine output charting. In maternal assessment, we go on with CBC, platelet counts, coagulation profile, serum uric acid on creatinine, LFT, urine for protein, ophthalmoscopic examination, ultrasonographic KUB with renal artery Doppler. We can do it fortnightly, weekly or daily according to the severity. In fetal assessment, we go on with daily fetal movement count, clinical examination, non-stress test, biophysical profile, obstetric biometry and Doppler studies. In complications of preeclampsia, we have certain immediate complications and remote complications. In immediate maternal complications during pregnancy, we have eclampsia, antepartum hemorrhage, acute renal failure, cardiac failure, HELLP syndrome, vision disturbances and premature labor. During labor, we have eclampsia, postpartum hemorrhage and shock. During perpurium, we have eclampsia, perpurial sepsis and shock. In fetal complications, we have intrauterine death, fetal growth restrictions, birth asphyxia and prematurity. In remote complications, we have residual hypertension, recurrent preeclampsia. Now, the major question is when we have to start antihypertensive drugs in pregnancy. So, according to NICE guidelines, when diastolic blood pressure is more than 90 mmHg or systolic blood pressure is more than 140 mmHg, we can go on with antihypertensives with a target pressure of 135 to 85 millimeters of mercury. Antihypertensive drugs that are safe during pregnancy are oral, we have labetalol, nifedipine and methyl-dopa. In intravenous, we have labetalol and hydralazine. That antihypertensive drugs that are avoided during pregnancy are ACE inhibitors, angiotensin receptor blockers, diuretics, non-selective beta blockers, example propranolol. But the labetalol is the drug of choice. Magnesium sulfate is the major drug which can be given in prevention and treatment of eclampsia. It is a membrane stabilizer and neuroprotector It blocks the glutaminergic NMDA receptors. We can give it through certain regimes, that is IV and IM regime is Pritchard regime, in which we give loading dose of 4 gram intravenously, 20% solution over 4 to 5 minutes, followed by 10 gram intramuscularly, 50% solution, 5 grams in each petal. Then we have maintenance dose of 5 gram intramuscularly every 4 hours in alternate petal. In IV regimes, we have Suspense regime and Sibai's regime. So if BP is controlled and there are no severe features, routine antenatal checkup is followed till 37 weeks and then we go on with delivery of the patient. If preeclampsia presents with severe features and pregnancy is less than 34 weeks, we admit and monitor the patient, stabilize the maternal and fetal status, continue till 34 weeks if not possible for 37 weeks, BP is controlled on antihypertensive and steroid cover is given. If there is persistently high blood pressure despite antihypertensive to severe level or addition of ominous symptoms, we go on with couple counseling. We transfer to the tertiary care hospital, prophylactic MGSO4 is given and steroid cover is given if less than 34 weeks. Delivery is carried out irrespective of the duration of pregnancy. Gestational hypertension and preeclampsia without severe features is present, then we go on with vaginal delivery. But if preeclampsia presents with severe features and it is removed from term, we go on with cesarean section, or if it is near term, we generally prefer vaginal route. But the final mode of delivery depends upon the obstetric indications. In anesthesia, we generally prefer regional anesthesia because general anesthesia has risk of aspiration, failed intubation due to laryngeal edema, stroke. MGSO4 is to be continued during cesarean section because if we stop it, it can lead to increased risk of seizures. In intrapartum management, we go on with antihypertensive drugs. Blood pressure and urine output are frequently noted. Careful watch of signs and symptoms of impending epilepsy. Prophylactic MGSO4 is given if BP is more than equal to 160 upon 110 mmHg. Careful monitoring of fetal well-being. Labor duration is curtailed in first stage by low rupture of membrane and in second stage by forceps or ventouse application. Intravenous ergometrin following delivery is strictly contraindicated. In postpartum surveillance, we go on with strict surveillance during the first 48 hours, monitor blood pressure and urine output, antihypertensives as required till diastolic blood pressure is less than 100 mmHg. MGSO4 is continued until 24 hours after delivery or last seizure episode, whichever is later. Diuretics and invasive monitoring reserved for patients with pulmonary edema, refractory oliguria, refractory hypertension, renal and cardiovascular complications. Thank you. Now I would like to hand over the mic to my colleague from the Department of Medicine.
A very good morning to all the dignitaries, teachers and my dear colleagues. Today, I, Nandini Sharma, stand before you on the behalf of my team, Lakshna Singh, Pallab Jain, Renu Saini and Ritika Agarwal to present the 10th UGCR on the topic hypertension, focusing on the National Program for Prevention and Control of Non-Communicable Diseases, under the guidance of Dr. Rajat Vora Sir, Professor and Head Department of Community Medicine, and moderation of Dr. Anjali Jain Ma'am, Department of Community Medicine. Adding to our knowledge of hypertension, let's take a look at the prevalence of hypertension in India. In the age group of 15 and more, 21% women are hypertensive, while 39% are pre-hypertensive. On the other hand, 26% of males are hypertensive, while 49% of them are pre-hypertensive. This is the graphical representation of the previous data. Moving on to the rule of halves, it states that in a population, half are hypertensive and half are normotensive. From the hypertensive population, only half of them get diagnosed. The people who got diagnosed, only half of them seek treatment. And only half of those people are adequately treated. As we all know, hypertension is a part of non-communicable diseases. So here are some risk factors. The major being tobacco use, sedentary lifestyle and air pollution, physiological being obesity, raised total cholesterol, non-modifiable being age, genetic factors, and modifiable being salt intake, socioeconomic status, and environmental stress. Moving on to prevention of hypertension. Primordial prevention focuses on preventing the onset of the risk factors through avoiding junk food, cessation of smoking, increase in physical exercise, and discouraging children from adopting sedentary lifestyle. Primary prevention adopts two strategies. Primary strategy focuses on non-pharmaceutical interventions such as nutrition, weight reduction, behavioral changes, and health education, while high-risk strategy focuses to prevent the attainment of the level of PP which requires treatment. Secondary preventions detect and control the blood pressure in affected individuals through early case detection, treatment, and patient compliance. Pertaining to the risk and prevalence of hypertension, the Government of India has launched National Programme for Prevention and Control of Non-Communicable Diseases. Along with hypertension, it includes cancer, diabetes, COPD, asthma, non-alcoholic fatty liver diseases, and chronic kidney diseases. The timeline of the program goes like, it was launched by the Government of India in 2010 as National Programme for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases and Stroke in 100 districts of 21 states. In 2013, it was presumed under National Health Mission. Presently, NPCDCS is renamed as NPNCDs, including COPD, STEMI, chronic kidney diseases, and non-alcoholic fatty liver disease. The objectives of this program are health promotion through behavioral changes, screening, early diagnosis and management, strengthening supply chain for drugs, equipments, and logistics, monitoring, supervision, and evaluation through proper implementation, and coordination and collaboration with other national health programs. To achieve the objectives, here are few of the many strategies. Evidence-based standard treatment protocol, uninterrupted drug and logistics supply, task sharing and people-centered care, implementation of research and generation of evidences, and multi-sectorial coordination with other national programs. Operational strategies adopted at various levels are: at community level, active enumeration of eligible population, registrations and risk assessment, along with health promotion and lifestyle modification is ensured. At the sub-center level, screening of diabetes, hypertension, and 3 common cancers, dispensing of prescribed medicines, generation of ABHA IDs, and referral of suspected cases to PHCs is done, where screening of NCDs and confirmation of diagnosis, treatment, and management is ensured. At the CHC level, opportunistic screening for diabetes, hypertension, 3 common cancers along with COPD is ensured. At the district hospital level, diagnosis and management of complicated cases and follow-up for chemotherapy and palliative care is done. At the medical college or tertiary care center, diagnosis and management of complicated cases of common NCDs, comprehensive cancer care including prevention and early detection, and support programs in capacity building and preparing guidelines and protocols is done. This is a diagrammatical representation of the previous slides. At the village level, ASHA does the enumeration and risk assessment of the eligible population through ASHA app. At the sub-center, the ANM or the CHO does the screening of the NCDs and the follow-ups. At the PHC level, the MO manages the simple cases of NCDs. And at the district hospital or CHC level, management of complicated cases of NCDs is done. All the information is updated on the NCD portal. To strengthen hypertension, treatment and control, the Ministry of Health and Welfare, in collaboration with Indian Council of Medical Research, WHO Country Office and State Government, has launched the Indian Hypertension Control Initiative, IHCI, in November 2017. It has adopted a goal of 25 by 25, which aims to reduce the premature mortality due to hypertension and other NCDs by 25% by 2025. In its first phase, it covered 26 districts of 5 states, expanding to 52 districts of 10 states by December 2020. These pictures show the working and progress of IHCI program. Dietary approach to stop hypertension, aka the DASH diet, is a flexible and balanced eating plan that helps create a heart-healthy lifestyle. It focuses on a 2,000 calorie a day diet, including 2,300 milligram of sodium. It recommends eating vegetables, including low-fat dairy products, limiting food high in saturated fats, limiting sugar-sweetened beverages, and limiting sodium intake. These are some of the dietary servings recommended under the plan. Concluding today's session, I would like you all to take a look at a short video by WHO. These are the references taken in the making of these slides. Thank you so much.
Thank you very much.